Good morning. My name is Ambrazo. I'm the founder and CEO of MPN Advocacy and Education International, and have been in this space for quite a few years. And I'm very happy to be with you today in another conversation with the specialists. And our specialist today is Dr. Gabriella Hobbs from Mass General in Boston. And she has spoken at several of our programs in the past. And today we have her all to ourselves. And she is going to talk about interferons and MPNs. She recently wrote a paper about interferon, and she will share some information with you, and then it's open to questions. So please send your questions through a chat or to Mallory, and we will make sure we ask Dr. Hobbs. Welcome, Dr. Hobbs, and thank you so much.
Thanks so much, Anne, for having me. I am really excited to be talking to you about interferon. I have definitely spent a lot of time this year talking about interferon with my patients with the approval of ropeg interferon. So it's a great opportunity to just spend some time talking some basics. I was talking with one of my patients yesterday who was on interferon, and she's like, but what is actually interferon? So great opportunity. I hope she's on the call. Let me start from the beginning. So before we really get into what interferon is and how we use it, I just want to remind ourselves of what is our treatment approach for patients with MPNs. And specifically, I'm going to talk really about polycythemia vera and essential thrombocythemia, or PV and ET, because that's really where we utilize interferon. So for polycythemia vera patients are divided into risk of having blood clots. This is not risk of their disease in general. And if patients are younger than 60, and if they haven't had a blood clot, they're considered low risk. If they have any of those risk factors, then they're considered high risk. In ET, we have a little bit of a similar risk stratification system, but there's some variation to that. So patients are divided into very low risk, intermediate, high, and very high risk. And the categories we use are, or the variables we use are age less than 60, having or not having a JAK2 mutation, and having had a previous blood clot. And so when you look at the treatments that are available, the biggest change really is that for the low risk polycythemia vera patients, we now have the option of using ropeg interferon in addition to using aspirin and phlebotomy to control blood counts, or just really using ropeg interferon alone if that controls blood counts well enough. For patients that need what's called cytoreduction, or getting a medication to reduce blood counts, we have obviously interferons as an option, and we have hydroxyurea as an option for both PV and ET. And then for polycythemia vera patients, those that don't do well with the first choice of treatment can be treated with ruxolitinib or Jakafi. So let's talk a little bit about interferon. So interferon is a type of molecule that is made by our immune system. It is made by a type of blood cell called T cells. And the reason why we feel sick when we have a cold or an infection is in part because of interferon. Our blood cells respond to that invader by making interferon. And one thing that I think is absolutely fascinating is that we've been using a form of interferon to treat myeloproliferative neoplasms for over 3 decades already. And there are several different types of interferon. So in the body, there's several different types of interferon, but we utilize what are called type 1 interferons for treatment. So the first interferon to be used was intron A, or standard interferon alpha 2B. This is what's called unpegylated, and basically it didn't last in the body that long, and so it had to be administered several times a week, and that probably led to some of the side effects that were experienced by patients, and really also gave interferons a bad reputation because it is significantly less well tolerated than the newer interferons, causes lots of flu-like symptoms. And now that you know that interferon is responsible for causing flu-like symptoms when you do have the flu, you understand why this is one of the side effects. Then we had 2 different types of pegylated interferon, Pegasus and Pegintron, and these medications were better tolerated, given once a week. And the PEG refers to just how the molecule is modified to make it last longer and stay in circulation longer. And then because it's administered less frequently, it also has less side effects. And then most recently, and the reason why I've spent a lot of time talking about interferon with patients is because there's been obviously a lot of excitement about the most recent approval, and that is Ropig interferon alpha 2b, or Besremi, that was approved at the end of last year. So why is interferon exciting, and how does it work in myeloproliferative neoplasm? Well, the short answer is we don't have all the answers. We have some theories about why it may work, and so I'm going to share a few of those with you. So interferon alpha can augment or can improve the activity of immune cells, in particular T cells, which we've discussed already, which are a type of immune cell, among other immune cells like these cells called macrophages and NK cells. And that's important because we know that our bodies have the ability to detect cancer cells and cells with abnormal gene mutations. And so augmenting that activity may be helpful to getting rid of those invaders or those cells that don't belong there. And along those lines, interferon can help the immune system to recognize the MPN cells, or cells with the MPN mutations. The other thing that's very intriguing is that JAK2 mutated stem cells seem to be more sensitive to the effects of interferon than normal cells. And what this does, and has been demonstrated in mouse models of MPNs by one of my colleagues, Dr. Mullally, is that interferon makes JAK2 mutant stem cells. So when patients have mutations such as JAK2 or calreticulin, the stem cells are the ones that have those mutations. And interferon helps them mature and ultimately get into the program for cell death called apoptosis. And so over time, we think that having administration of interferon can help to reduce the amount of stem cells that have this JAK2 mutation. And this here is really why I think that interferons have a lot of potential and have made us all pretty excited to administer this medication. So let's talk about interferon in clinical practice. How is it used? What are the benefits and what are the downsides? So we know that interferon reduces blood counts and blood clots. We know that it can improve MPN-related symptoms, but we'll talk a little bit more about that. It can, like I said, normalize blood counts over time and can reduce the mutation level. And it's a non-chemo intervention, which is particularly attractive to our younger patients, but patients in general. Now, what are some of the downsides? It can cause flu-like symptoms. It can cause abnormalities in the liver function test, or LFTs. It can be associated with autoimmune effects, for example, thyroid dysfunction. In some cases, it can lead to depression, although this is rare, it does happen. And it's a subcutaneous injection, which may be more difficult to administer than a pill. So we're going to spend some time, I'm sure, and I'm going to get plenty of questions on Ropig interferon. And so Ropig interferon is another type of pegylated interferon that's different to the interferons that we had before, and that it's administered every 2 weeks. It's a subcutaneous small injection, similar to pegylated interferons that were available before. And eventually it can be utilized as a monthly maintenance drug as opposed to every 2 weeks. And here is a slide that I'll spend a little bit of time talking about that I think is really summarizes why it's exciting to utilize the interferons. So the red line represents the level of the JAK2 mutation in patients treated with Ropig interferon in the Ropig interferon studies. And the gray line represents the JAK2 level in patients treated with control, which was primarily hydroxyurea. And what's so interesting is that although the effect is not quick, it is consistent. And over time, the level of that JAK2 mutation goes down over time. And so I'm sure that I'll get some questions about that, but this is really, I think, why this is so exciting. So, and again, I'm sure I'll get some questions about this, but I'll preempt them anyway. There are a lot of unknowns, even though there seems to be a lot of promise. And so some of the questions that we're asking ourselves is, do reduction in mutant allele burden, or the JAK2 levels, lead to decreased rates of transformation, meaning that when PV or ET turn into myelofibrosis and leukemia? Does long-term use of interferons lead to improved survival? And should interferon be used for all patients with early polycythemia vera? Is there a difference between the interferons? And some of my patients that have been on Pegasus for a long time want to be on Ropig. Is it better to be on one or the other? And then should interferon be used for all young patients? So these are some questions that we can discuss in more detail. So thank you for your time. And now I'd be very happy to take questions.
Okay, thank you for that, because I sat here and I looked at Mallory and said, I always try to read about how interferon works in our bodies, honestly. And you nailed it. That was great. So a couple of questions. And of course, the big one is, what is the difference between Besremi and PEG? And not only, when you inject or when you take, when you are treated, but what is it the long-term effect of Besremi? That's the difference. And the big thing for us is the fact that Besremi was approved by the FDA for an MPN. So, so your thoughts on that?
No, and great question. And you preempted some of the answers. So I think one thing that's really very important is that ropeg interferon, or Besremi, is really the only interferon that was actually FDA approved for MPN patients, for PV in particular. And I'm assuming eventually it'll be approved for ET as well. And that's not insignificant. That's important in terms of being able to get it approved for use. And also that it's just been specifically studied in this population, and it's undergone the rigorous testing that is sufficient to give the FDA the go, or get the go ahead from the FDA.
Right.
That being said, it's not to say that the other interferons haven't been studied. Pegylated interferon has been studied actually in what are called randomized control studies by the Myeloproliferative Disease Research Consortium, comparing it to hydroxyurea. And so we do know about the other interferons also. But it's difficult to really know what the real differences are between Pegasus and ropeg interferon. The obvious one, of course, is that it's not FDA approved for the same reason, and that one is once a week and the other is twice a week. I will say anecdotally, it does appear that ropeg interferon is better tolerated in several different ways. Ropeg, it's only given twice a week, so it's a little bit easier. I would say that some of the malaise or flu-like symptoms doesn't happen as much with ropeg interferon compared to Pegasus. And I've seen less of the liver function test abnormalities that are really pretty prevalent with Pegasus. And then the other thing, which may sound trivial, but I know that people on this call will appreciate this, ropeg interferon comes in pre-filled syringes. And that is actually really wonderful, because since Pegasus is not FDA approved, getting Pegasus and then getting the syringes and the needles and all those things actually can be really challenging. And the volume that you have to give of Pegasus is really tiny. And so coaching some patients to give themselves the right volume of Pegasus is actually really difficult. And so those are kind of some differences, some of them that are more practical than biological.
I'm really glad you brought that up, because we've had patients on Pegasus that open the vial, which, after you use it, they're supposed to get rid of it, but they save it because of the cost, and it's being saved. Some people are sharing it with other people because they can't afford it. I mean, so there's some real social and kind of moral issues behind that as well. Okay, so we have tons of questions already, which we knew was going to happen. You did mention some of the side effects from interferon, but how does interferon conflict with the good JAK in a person's body? So I'm not sure if I'm saying this correctly, but does it cause other problems because of what it is?
So interferons are not selective or specific just for the MPN mutated cell or just for the diseased cell. And this is true really of most medications that we have in general, and specifically for MPN. Like I tell my patients, I wish I had a smart medicine that just went after the JAK2 mutation, but that's not the case. And because of this, interferon is a molecule that's made by your immune system. And so many cells in the body have the potential of responding to interferon. And, when it turns on T cells and cells in the immune system, you're going to see these, fever and malaise and and make the T cells wake up in a weird way and respond to something that they're not supposed to. And for example, that's why we see some patients having autoimmune thyroid effects, because a group of T cells that was previously dormant woke up and decided to attack the thyroid instead of just kind of being dormant. And so those are some of the effects that are not specific.
Does having a TET2 mutation along with JAK2 make interferon less effective? And if so, is there anything that can help mitigate that?
Great question. And we don't really know. There may be some data to say that patients that have a more complicated MPN with more mutations may respond less to the interferons, but that's not really known. And it really wasn't studied specifically in the roping interferon study. So we actually don't know that. So hopefully, we can follow that moving forward and can have some more information, because I think that's a really relevant question. And I think that not all additional mutations are made equal. There's some mutations that probably matter less than others. And the TET2 is a pretty common mutation. So there's really nothing that can be done to kind of get rid of that TET2 mutation. But I wouldn't say that having a TET2 mutation is not a reason. I mean, having a TET2 mutation is not a reason not to get roping interferon. You're definitely still a candidate for it.
So aside from the molecular changes or assistance with interferon, you know this better than anyone, treating patients, but the itching, the bone pain, the symptoms. Do the symptoms subside a bit or go away, and particularly itching with interferon?
Yeah, that is a great question. And I think that I'm glad that question was asked, because although I have personally prescribed a lot of interferon in my time as an MPN physician, it is important to recognize that interferons, as of today, they're not like a cure for everybody. And so I think that although it's good for all of us to be excited about the potential of this treatment, we also shouldn't lose sight of what's important. And that's, treating the patient and helping people feel better. And although for some patients, interferons really do make a lot of the symptoms go away, for some patients, it doesn't help as much. And I think that's not a reason I don't want people to think that because interferons are these potentially amazing medications, that you should say, I'm not going to take a medicine that I know may help me with my symptoms because I have to be on interferon to get better. Or potentially get cured, because like I was saying when I was presenting, we don't actually know the long-term benefit of being on interferon. And when you look at the changes and mutations over time, those are very slow changes. And so if a patient has a lot of itching, is it not worth trying interferon? Sure, it is, but it just may not take care of all the symptoms. And so you have to have a discussion with your doc about what's right for you, and maybe consider medicine like ruxolitinib or Jakafi that really has been studied specifically for symptoms and happens to be very good specifically for itching.
If PV is manageable with aspirin and phlebotomies, is it worth looking into interferon treatment? We hear this all the time. Yeah.
So let me clarify something, and I'm so glad you asked that. So remember how I put up the slide about, how do we define low risk and high risk and who should be treated with what? So there was a study comparing phlebotomy and aspirin to ropeg and aspirin. And not surprisingly, getting a medicine to control blood counts was better than not getting a medicine to control blood counts, because phlebotomy is a pretty old-fashioned way of treating people. I hope that eventually we can get rid of that. And so phlebotomy was not that good at controlling blood counts. And I think that anybody that's gotten phlebotomy is not probably surprised about that. And so just because roping interferon can control blood counts better than phlebotomy doesn't mean that every single PV patient needs to be on roping interferon. And so that's where we get into these kind of discussions about, okay, so I understand that roping is going to control my blood counts better. If your blood counts can get well controlled with phlebotomy alone, you don't have to be on roping interferon. The next question is it worth getting on roping interferon early for the potential of decreasing my JAK2 mutation? And is it better to start on a medicine that can lower my JAK2 mutation early because it takes such a long time to lower that JAK2 mutation. And that's really a one-on-one discussion with providers. I hope that at some point I'll get back on this call and we'll have some data to say, yes, if you start early, and yes, if you start with a low JAK2 level to begin with. There are some patients where the mutation goes away and now we have this other medicine that really keeps it away or whatever. But right now we really don't have that information. I cannot tell you, and nobody can tell you, that if you start that JAK2, that interferon early, you're going to get cured of your disease. So it's important to not overpromise what these molecules can do.
Yeah, because there are, as you know, there are several schools of thought out there in the physician, MPN physician community, that there are some scientists that say, yes, start early, but I agree with you on that one for sure. If my allele burden is below detection, can a patient stop interferon? Does ET come back? Boy, that's
a wonderful question, and along the same lines of the prior question. We don't know. There are definitely some anecdotal studies that say that some patients can definitely stop their interferons and the disease doesn't come back, but I don't know for how long it doesn't come back, or is it forever? I think one of the things with MPNs that's important to keep in mind that these are not diseases that need to be treated urgently. And so if your JAK2 mutation is undetectable, you probably have or should consider, decreasing how frequently that interferon is given and see what's happening. And if your blood counts stay well controlled, you can continue to increase that interval until potentially you can just take a break from the interferon and see what happens. But this is an area that's unknown with no clear data to really say this is what you should do exactly in this scenario. We don't know.
Right. Because we do know a few patients actually that were on interferon and were in remission for quite some time, and it did come back, and but they did have this hiatus that was, some pretty wonderful. Okay, boy, we've got tons of questions here. Okay. Can I expect the same results on interferon with the CALR mutation?
Yeah, that's a great question. Yes, patients with a calreticulin mutation can also expect a decrease in their mutation level over time. I would say that it has not been studied as thoroughly as JAK2. And remember, ropeg interferon is currently only approved in the United States for patients with PV, and the vast majority of PV patients have a JAK2 mutation, and essentially patients don't have calreticulin mutations with PV. And so we don't have those same data for ET patients that have calreticulin mutations on ropeg because it just hasn't been done. So patients have, of course, been treated with the other interferons with ET and still have a benefit. But that's something that we're going to have to kind of study more over time to see if the benefit is the same or different with calreticulin, because there's definitely been some studies suggesting that maybe the benefit is not as profound, but we also just haven't had enough studies.
Okay. If I'm on Besremi long-term, would I need to get labs every 2 weeks? And if my counts are normal on Besremi, do I need to continue taking baby aspirin?
Two great questions, and I'm so glad those questions were asked. So initially, when a person first starts Besremi or ropeg interferon, it is important to have labs monitored maybe every 2 weeks at the beginning, or maybe every month at the beginning, really to see two things. One is are the blood counts getting well controlled? But remember, the average time that it took for people to get blood counts controlled was close to 8 months. So you're not going to see a difference in 2 weeks. And so really, we don't necessarily need to be checking them that often, unless, for example, some patients were on hydroxyurea or Jakafi at the time that they started. And so then you and your care team need to decide, how you taper off of your other medication, or if you need phlebotomy or those kinds of things. So that's really what's driving checking the blood counts initially. What are you doing with phlebotomy and your other medication as you're starting ropeg? And then the other reason for checking blood when on Besremi at the beginning is to make sure that there aren't any abnormalities in liver function tests. But again, that doesn't necessarily have to happen every 2 weeks, maybe every 2 weeks the first month. But if your blood counts are well controlled, you're on the 500 microgram dose, not having any issues, not having any side effects, I think it is important, really important to advocate for less blood work. I know some of my patients, if they're on the call, they're going to laugh because they love to see their blood counts. Some really frequently, despite me saying, really, it's okay. You don't need to have your blood work checked. And I think that's really something to actively work on. Sometimes more data is not better. There is a lot of anxiety that's around, associated with getting blood work done. I think that we are all like pretty logical people, and we just expect to see consistent trends and numbers that make sense from one lab draw to another. But the truth is that like we're human beings and we're not that consistent. And so there are variations between one lab draw and the other that actually cause a lot of anxiety and issues. So I would recommend to you that if your blood counts are really well controlled and you've been on a stable dose, that you really only check your blood counts every couple of months. And then in terms of aspirin, yes, one must remain on aspirin because the disease is still there. So you're still at risk for having blood clots. And so every study that's been done has included, or the recent studies have included, both aspirin and the medication to lower blood counts.
Excellent answer. And this is a person who is in their mid-70s and are wondering if they should start Besremi in this age range, or is it best for younger patients, or is hydroxyurea just as good for this age group?
Wonderful question. And it's a difficult question to answer because none of us know how long we're going to live. And so I think it's a matter of kind of seeing a bunch of different things. Are you somebody that is able to administer a subcutaneous injection? Are you a person that has other medical issues, maybe liver function issues, or already having autoimmune issues or anything like that would make, roping interferon maybe not the best medication? Or is the reason for starting on blood counts, on a medication to lower blood counts, also related to symptoms? So maybe roping interferon is not the best medication to start. But I would say just because somebody is in their 70s doesn't mean that they cannot be on roping interferon, but it is important to kind of take into account all the reasons why we need to be on a medicine to lower blood counts. And kind of going back to what I had said before, the reduction in allele burden or the level of the mutation is a slow reduction, and we don't know what the long-term benefits are. And so, if you're going to choose roping interferon, you need to be aware of that. But it doesn't mean that you can't be on it if you're in your 70s.
And this person is currently in a hematological remission and has seen a reduction in their JAK2 mutation and have reduced frequency of PEG. Is it better to lower my dose every week, or should I do the usual dose every 2 weeks?
If you're on Pegasus, that's really up to you. Some of my patients find that when they skip a week, maybe the next time they give the medication, they don't feel that great. So they prefer to do every week, but at a lower dose. And some patients just really prefer to have less frequent administration. And so they just kind of space it out at the same dose. So I think it's perfectly fair to play around with that and see what works out best for you. But I think being on less medicine is definitely always the goal. And so if you can reduce either how frequently you get it or the dose that you're taking because you're in that remission, I think that's absolutely worth doing. And you just need to engage your healthcare team to say, this is what I'd like to do. How do you suggest that we do this? And just be open to a little bit of experimentation, because you may respond to the different doses differently than other folks.
And this question, I think we kind of talked about it, and you highlighted it as well in your slides. But so this person would love your opinion on the 5 Qs on the second to the last slide in your presentation. Should a younger patient take interferon? Does it improve life expectancy? Is it the preferred initial treatment in newly diagnosed patients?
Well, when I have the answer to those questions,
Yeah, no kidding.
I will definitely let people know. I don't know, really, I don't know. And it is really tempting. I have to say, it is really tempting to start roping interferon for younger patients. I have to admit that I have definitely been tempted by that. I have a young woman who's 19, and she had some symptoms, which I bet you before the approval of ropeg interferon probably wouldn't have started her on anything, and now I started her on ropeg. But everybody is different, and I can't overemphasize, honestly, that we just truly do not know if these medications make people live longer, if they prevent transformation from PV to myelofibrosis or to acute leukemia. But it is very tempting to at least contemplate that, because we do have other diseases where we monitor the levels of mutations. So we're not alone in the MPN world. I would say that in the next decade, you should expect that to be the norm. For other diseases, we really monitor mutation levels all the time, and that really guides our decision making. So I wouldn't say that we're making it up when we say it has to be a good thing that we're lowering the JAK2 mutation level, because it is good for many other blood diseases that we treat. And so what I would say, and what I tell my patients, is if you are going to start roping interferon, mostly because of the promise of decreasing JAK2 allele burden or JAK2 levels, you need to be aware of the fact that you are subjecting yourself to the toxicity of a medication, because this medication can still have side effects, both physical and financial, for an endpoint that we actually don't know the answer to. And so, like Anne had said, there are a lot of physicians that feel very passionately that this is what should be done for everybody. But I would just tamper that, put the brakes on the excitement just a little bit to say, we need to go into this with our eyes open and be aware of the fact that we just don't really have the answer to that question for everybody. And moreover, we don't know which patients are the ones that are really going to go into these molecular remissions and which ones are not. I think that's something that would be great to both answer, so that I can see in advance, like, I know that you're not going to respond, like, I'm not going to subject you to this. Or if I could give you something else to kind of make sure that you do have that response. So that's, I think, an area of research that needs to happen.
We started a MPN pediatric and young adult program, and have probably several of those folks on this call today. Mm-hmm. And I see, as a mother and grandmother, and you're a mom of young children, I can thoroughly understand, they're seeking and wanting answers for their younger child who has an MPN and who could live with this for many, many years. And so, I do know several that are on interferon, and the children are doing pretty well, and are living life and in college, and, and some are even younger in middle school. But so jumping to the other side of that is a gentleman who's much older, who's been on HU for 35 years.
Wow.
Has hit what we call a spent phase. The HU doesn't seem to be controlling the platelets and doing the job it did earlier. Would you recommend to someone like him interferon?
Well, so I think we need to be careful with that spent phase description, and many times we use that as a surrogate way of talking about myelofibrosis. And so if the issue is just that all the blood counts are really high, and there's something going on with that patient for which, the same dose is not controlling the blood counts because they're high, that's one thing. But that's not the same thing as, now my blood counts are really low and I have this big spleen and I have a lot of symptoms and I'm not feeling well. And if that's what's going on with this gentleman, I think it's probably time to take a pause and see what's actually going on, and has a bone marrow biopsy been done. And if a patient is diagnosed with myelofibrosis after having PV or ET, ropeg interferon and the interferons are really not, have not been effective for myelofibrosis. And so I would say that person probably needs something different. That's not
If
interferon.
right, if they have converted, correct? Yeah.
Exactly.
Yeah. All right. So the recommendation would be get a bone marrow biopsy and, talk to your physician and see if anything's changed. So you also know that we do a women in MPN program, and lots of women ask this question, who are young women who would like to get pregnant or are pregnant, and what should they take or what should they stop? What medicines for MPN should they stop? What should they take? Could you please respond to that?
Absolutely. And what a good question. So what you should definitely be on if you are pregnant is aspirin. We have studied the outcomes of women in pregnancy across several hospitals in Boston. And the one thing that is consistently critical for having good outcomes in pregnancy is aspirin. Even if you were a patient that was previously not taking aspirin because maybe you're a low risk person with a calreticulin mutation, for example, but during pregnancy, I would say everybody should be on aspirin unless there's a reason not to. Then the question comes up about, should I be on a medicine like interferon of some sort during pregnancy? And most women really don't need to be on a medicine such as interferon during pregnancy. If you're somebody that was already on interferon, not because you wanted to be on interferon because you have low risk PV, but because you've had a blood clot in the past or there was something that was high risk about your disease. So if that's the case, then I would say, the first trimester, we really don't have great data to say that the pegylated interferons should be used. The pegylated interferons should not be used in the first trimester of pregnancy. And so that leads to, the non-pegylated interferon, which is actually pretty difficult to tolerate. So that's a one-on-one conversation. Is it possible that you could maybe stop interferon for the first trimester, depending on your situation? You can then consider taking pegylated interferon later in pregnancy. As far as I know, ropic interferon has not been studied during pregnancy, so I can't really advocate using that in pregnancy. And then the next thing to consider is if you're somebody that needed to be on a blood thinner prior to pregnancy because you've had blood clots before, then you should continue a blood thinner during pregnancy, but you're going to be on a different blood thinner. You can't be on warfarin or Coumadin during pregnancy, and you can't be on the oral anticoagulant either. The other ones, you need to be on what's called like a low molecular weight heparin injection during pregnancy. And if you're somebody that has not been on a blood thinner prior to pregnancy, what we recommend is just doing 6 weeks of the low molecular weight heparin, the injections, such as enoxaparin, for 6 weeks after delivery to prevent blood clots then, because that's a period of high risk. So just as a short answer, everybody should be on aspirin. Outcomes with pregnancy and MPN are pretty good. It's just a matter of having, pretty honest conversations with your doctor and finding a high risk OB that's comfortable, following somebody that's going to have abnormal blood counts during pregnancy. And then the other thing to remember, which is kind of interesting, blood counts kind of normalize a little bit during pregnancy. It's kind of fascinating. And so you can expect your blood counts to get better during pregnancy. They will return back to normal, unfortunately, afterwards.
Okay. And this question came up earlier, but can you explain scientifically the difference between HU and interferon? What specifically is the difference?
Sure. So HU is a chemotherapy agent in the traditional sense of the word. And what does that mean? Because every drug is really a chemotherapy agent. It's a chemical that you put in your body that doesn't belong there, or doesn't happen normally. So HU is a chemotherapy drug, and that means that it gets in the way of DNA replication, of cell replication. So it gets in the cells and it just kind of stops the process of cell division. So that's chemo. That's what hydroxyurea does. Interferon is not that at all. Interferon is a molecule that is naturally occurring in your body, that is made by cells in the immune system. And we basically take that structure and then use fancy technologies to make that in the lab. And then we modify it or, adjust it to add another molecule to it to do what's called the pegylation, so that molecule lasts in circulation longer. It's a protein. Interferon is a protein. So they're different in their structure and how they act on the body. You know, HU gets into the cells, stops them from dividing, and interferon has these almost magical effects by, you know, turning on cells in the immune system and then making those stem cells that have the mutations turn on pathways that they maybe hadn't been able to do, and then lead themselves to do what's called apoptosis or programmed cell death. And so very, very different in the way that they act because of what they look like.
So we talked a bit about the storing of interferon and when a patient doesn't use all of it and still needs to store it. I mean, the expenses is pretty bad, you know, pretty difficult for most people. So what would your recommendations be in terms of storage, the best way to store it so it can be used over the month? And you just kind of answered this question, is Pegasus better than HU? I know it's a little different, but you know, because we know a lot of patients that it was recommended that they throw the vial away after it's unsealed. But what would your suggestion be?
So I'm going to actually take a step back and say, don't be shy about speaking up about what you have to do in order to get these medications.
Yes.
They are expensive. And I wish that as a physician, I had any control over that. But I do, at least in my institution, work very, very, very closely with my pharmacists, access nurses to help patients apply for patient assistance programs, grants, et cetera, so that they can get this medication covered. And so first and foremost, before you start considering alternative ways of dosing yourself, you should speak up and try to get some help, because that does exist. There are programs for patients to get assistance. And if you happen to be treated in a place by a provider that just doesn't use interferon that often, they may not know that, but you should ask about that. You can contact the company directly. I'm sure the provider can do that. And there's lots of different ways of getting assistance. So the first is to speak up. Yeah. The second, gosh, I wish I could tell you an answer. So, you know, the official way that it was studied, the way that people tell you to give it, et cetera, is that you can't re-administer it. Is something really going to happen to that medication if you store it for a few weeks? I know plenty of people do that, but I can't tell you the best way of doing that, because I personally haven't studied the interferon 2 weeks later or 4 weeks later to be able to tell you, oh, this is still just as effective. It hasn't degraded or anything. Nothing has happened to it. I've spoken to the company several times and I'm like, why don't you just give the 100 syringe, the 200 syringe, the 300 like that, so that patients don't feel, so distraught throwing so much money down the drain. But that hasn't happened. So I would say first and foremost, speak up.
Yeah. And to let those on this call know, or on this webinar, the PAN Foundation is also an outside source, but Dr. Hobbs is absolutely correct in terms of the companies that are willing to assist and help and give grants and so on to help you get your medicines. So if you ever have an issue, please let us know if you haven't let your these other entities know, and we can direct you to the appropriate place. Yes. Okay, so what about statins and the use of statins to treat PV? I believe Dr. Hassenbach in Europe is doing research on this. Do you know anything about that?
Great question. I mean, I think that we should think about the MPNs as another cardiovascular risk factor. And so when treating patients that don't have MPNs in a primary care clinic, we think about their age, their heart disease history, their family history, their smokers, if they have high blood pressure, diabetes, and those things. And based on that, providers can decide if they should use statins. And yeah, it's true. Many of us are definitely interested in thinking about utilizing statins because they do have a lot of effects, some anti-inflammatory effects in MPN patients, but they're not part of the guidelines yet, although hopefully having a lot of us doing some of these lifestyle intervention studies or interventions, just kind of modifying the cardiovascular risk of this, we'll be able to give better guidelines about using these other medicines that are used in just patients without MPNs to manage their cardiovascular risk factors.
Okay. Is there a certain JAK2 mutation percentage when interferon is the preferred treatment? And that goes along, piggybacks with the question of when does a physician, when do you make the decision to prescribe interferon to a patient?
As of now, there is not a level where we say now it's too high or now it's too low, or because it's too low or because it's too high, we won't give it or we will give it. So our treatment is not quite there yet. Hopefully one day it will be, and we'll have, guidelines to say, at 6 months, a patient's JAK2 mutation should have gone down by half, or at a year, it should go down by whatever, but we don't really have that yet. So stay tuned, I guess. And then what was the other question? No, now I lost track.
I did too. I'm reading these other ones. When do you make that decision?
When do we make the decision?
Yeah.
So that's something that I could talk about for, the whole time. And that's really based on the patient, but just to kind of be a little bit general, I would say it depends on, what does the patient need first and foremost? What is their risk stratification? Like, where do they fall when we do this, like, risk stratification? Is this a patient that's low risk or high risk? And when we're talking about risk for having blood clots. So if a patient is in the higher risk categories, then they need to be on a medication to reduce their risk of having blood clots, in addition to aspirin. And so then if that's where a patient falls, then, we discuss, is hydroxyurea the right thing for you? Is interferon the right thing for you? Remember, if you have essential thrombocythemia, as of this moment, that we cannot give Ropeg interferon, it's not approved. And so those are the conversations that we need to have. Is it the right time to start a medication to lower blood counts? And what's the right medicine for you? Perhaps your primary symptom is itching and you've been on Hydrea for a year and that hasn't taken away the itching. That doesn't mean that the next step has to be interferon. It could very well be ruxolitinib or Jakafi, and that would be a completely reasonable and excellent choice. That would definitely make you feel better. So it really depends on why the discussion is being had about blood count control or cytoreduction.
What test should be administered to determine the allele burden percentage? Is this important to know?
So there's different tests that measure JAK2, period. There's one that's what's called qualitative, which just basically says, yes, you have a mutation. No, you do not have a mutation. And then there's a variety of other tests that are a little bit more in-depth, that are called quantitative JAK2 tests, that can tell you the allele burden. And those can happen as like a single gene test where the provider only orders a JAK2 level, or that it's part of a panel. And I would say many hospitals these days have these panels that not just tell you if you have a JAK2 mutation or not, but they can tell you about other mutations as well. I would specifically ask your provider, are you ordering something that will give me that information about the variant allele fraction or not? Because some providers just don't either have access to that or don't routinely do that or think about that. And also remember, of course, we all like to see those numbers go down over time, but it's not part of our standard of care to check them over time. And we don't know necessarily when we should expect to see the JAK2 mutations start to go down. And so just make sure, kind of going back to one of the answers I gave before, that if you're going to check more blood work, that you understand what it means and that you don't end up just being disappointed or anxious because maybe in one of those tests, the JAK2 level went up or something like that. Mm-hmm. Because this is a slow moving medicine that's going to make that test go down very slowly over time. And it may, change so little that, you may end up being disappointed. So just be very aware of what you're asking for so that you're not setting yourself up for either a bill or disappointment.
Yeah. Do you have any information on the effectiveness of leukotriene inhibitors with PV? I think Dr. Lee was studying this at Mass General. Are you familiar with this study?
I would say leukotriene receptor antagonists or medications like that. I'm not exactly sure what's being referred to that in their question, but it can be very helpful for like itching and things like that. But not probably treating the disease itself, which is okay. That's an important part of the treatment.
How long do the side effects last, the flu-like symptoms last with the interferon therapy?
Everybody's really different there. I would say that some patients don't feel anything. Some patients have a day where they feel draggy. Some patients have a few days where they feel achy. And so really patients are really, really different. And I think it's just important to keep track of how you're feeling, and see when you have those symptoms so that you can better help yourself. So if you know that you give yourself the injection on Friday, and on, Saturday you don't feel anything, but Sunday you're under the weather or something like that, it's good to know that so that you can plan. So you can plan your life better, and then also plan the medications that you need to take. Perhaps that hour 23 you're going to start to get achy. Yeah, well then don't wait to get achy. Just take some either ibuprofen if you're able to, or Tylenol before, to just make those symptoms go away. MPN patients are tough and they don't want to have those symptoms, or they want to see what those symptoms are going to be. And so they don't want to block them by taking a medicine to not have those symptoms, but it's okay. You don't have to have those symptoms. So just go ahead and take those medications to make you feel better. You don't get extra brownie points for having more symptoms, but keep track. Everybody really is very different.
Yeah.
And also, I'll say one more thing. Just because there's this long, intimidating list of potential side effects to interferon doesn't mean that you're going to have any or all of those symptoms. Most patients have some, but most patients do not have all. So
yeah, and let's face it, every single drug on the market has this long list of side effects. And
true.
My daughter reads every single one if there's any medication in the house, but
it's almost best not to.
It scares me to, don't tell me. I'm that person that says, don't tell me. All right, if this gentleman or person is 73 with PV, let's see, would you want to take interferon or HU, and is Besremi worth the cost over HU? Again,
Great question. So it really depends on why you, what is the reason for starting on a medication to improve blood counts, and what other medical issues you have. If your insurance really just will not cover interferon, if despite patient assistance programs, you fall over the criteria for assistance, and you're going to end up paying thousands of dollars every month, I would say, honestly, not worth going bankrupt for a medicine that you don't know is going to improve your overall life expectancy in your 70s, or at any age, really. I mean, I think that we need to be really aware of why we're getting this fancy medicine. Of course, there's patient assistance programs and there's all these things, but some patients, the reality of life is that some patients will have to pay some money for this medication. And so if that happens to be you, then I would say it's okay to take hydroxyurea. There's nothing wrong with that. And another thing is, remember, when you make a decision to start a medication, nothing is forever. There may be bills in Congress being passed as we speak that are going to change how much patients have to pay for medications per year, et cetera. And so things could change, both not just on the legislative side of things, but also, there may be other medicines coming up. And so don't feel like when you make a decision to start a medicine, you're going to be on that for the rest of your life. It could change.
Yeah. What is the normal maintenance dose of Besremi? This person is currently on the maximum of 500 milligrams.
Yeah, so you stay on 500, and then you can move over to once a month after the first year, and you can consider that on a case-by-case basis with your doctor as well, if it makes sense to go to once a month earlier than that or not.
Are interferons helpful for MF patients with no enlargement of the spleen or liver?
Hasn't been as extensively studied. Ropig definitely has not. Maybe some studies have shown some, if there's going to be a benefit to interferons in myelofibrosis, is going to be in the earlier patients, but not, we don't really know that.
Yeah. And I think you touched on this earlier, but how long would one expect to see the spleen return to a normal size after being on Besremi and having blood count stabilized?
So, they didn't say this specifically in the studies with Ropig, but the average time to get into remission was about 8 months. So it takes a long time. If your spleen is really big, that that may be at least the time that it takes.
I don't know the answer to this, and you may not as well, but is hair loss a side effect from interferon?
I haven't seen it much. I've seen it more with hydroxyurea, but anything's possible.
And I actually read a study from COVID. If you've had the virus, the COVID virus, either Omicron or otherwise, that hair loss could be a symptom after. But who knows?
Yeah, many things can cause hair loss. It's very true.
I know. All right. So how would you treat a 60-year-old patient with increased platelets? And I don't understand this part, but JAK2 and a family history of MF.
So that patient, because they're over the age of 60 or 60 and have a JAK2 mutation, are considered to be high risk for blood counts, for blood clots, and therefore need to be on a medication to lower their blood counts in addition to aspirin. So we have the option of either Pegasus for that person or hydroxyurea. Obviously, if there's a clinical trial available for you to try aerobic interferon or something else, that's also a consideration. Those are the two options. And so it really depends on what else is going on with the patient, their preference, their desire to start Pegasus. Maybe they're not great with injections, or maybe they're not interested in the idea of taking a pill that is a chemo, even if it's a safe chemo. So those are the types of conversations I have with patients to help them decide what the right drug is to start.
Okay. So we have time for one more question, because I know your time is very valuable. And then I will just ask you to share your thoughts for the future of MPN treatments and the hopefulness, that I see in this field. And the last question is, should interferon only be used when indicated, or can we take it just because we are young? Currently, I have no symptoms, only have high platelets. I have ET, masked PV, and would like your recommendation.
Yeah, what a good question. And we sort of talked about this before. So, for PV, we have a little bit more leeway in that, the guidelines now say if you're a low risk PV patient, taking aerobic interferon is allowed. But the reason why it's there is because aerobic is better than phlebotomy at controlling blood counts. It's not just you should be on aerobic interferon because you're a young person that has an MPN, which is a little bit different. It's subtle but different. And so the other thing is to remember is you have ET, not PV. And so you should, in theory, can't be on aerobic interferon, not to say that some providers haven't prescribed it that way. But if you're a young person that doesn't have any symptoms, you're totally well, you're maybe not even on aspirin if you have a calreticulin mutation, you may not need to be on any medication. And if you are going to decide to start on a medicine, remember what I've been saying throughout this webinar. You are subjecting yourself to toxicities, both physically and financially, by taking a medication for something that we really don't know the answer to in terms of what this is going to do for your life expectancy. Is it really going to cure you of this disease or reduce the chances that this disease is going to progress to something else? And then these medicines, they do have side effects. And so you could be subjecting yourself to like having autoimmune thyroid issues by starting this medicine too soon. And so these are really conversations that you really need to have and be really honest about those answers. And then remember, these are slow moving medications also. So if you don't start it today and you start it in a few years, maybe in a few years, we'll have some more information. So don't feel like you need to rush to make that decision right away. And more importantly, hopefully you can have a conversation with your care team about what's right for you.
Thank you very much. And thank you so much for being with us today. It's always so great to see you. And if you'd like to share your thoughts and I mean, I've been around for so long, and I it's just remarkable how much has happened in this field and for these patients. And so if you wouldn't mind sharing, what you see coming in the future. And
so thank you all for asking all of these really, really wonderful and thought-provoking questions. As an MPN provider, I would say two things. One, I feel very optimistic for the future. I mean, the amount of clinical trials that are ongoing right now across the MPN spectrum is something unbelievable. Truly, there are so many medications that are being tested. But in addition to all of these new fancy medications, I want you all to just reflect and take one moment to take control of your health in general. One of the things that I think that we need to remember is that MPNs can be thought of as a cardiovascular risk factor. And so while I'm waiting for, these medications to be approved, take care of yourselves. If you smoke, don't smoke. If you have issues with weight, with blood pressure, diabetes, with cholesterol, or none of those issues, but want to prevent having those issues, a really important part of taking care of yourself as a person and also your MPN as a result is to use your MPN as a motivator to have a healthy and active lifestyle, because I do think that that'll help improve symptoms, reduce chances of having blood clots. And then if in the future you do need a medication, you will be so much better equipped to handle that medication. And so you can take control of your MPN as well while we're waiting for the results of all of these studies.
Thank you so very much. I mean, I can't believe anybody would disagree with that, Thank you.
Thank you so much, everybody.
And I hope to see you soon, possibly at ASH. And, I just really appreciate your time today, Gaby.
Thanks for inviting me. Always a pleasure.
Thanks. Bye now.